A 3-week-old female infant had a hemangioma, which is a rubbery bump or flat red patch that is made up of extra blood vessel in the skin. It is located on her right thigh and buttock, which was diagnosed at birth. An MRI performed when she was 7 days old, revealing the hemangioma increased in size and has darkened. Additionally, severe thrombocytopenia or low platelet count with a reading of 60,000 per microliter has also been observed. No familial history of hemangioma or other bleeding disorders are noted. To identify the origin of the patient's severe thrombocytopenia, the following tests were performed. Platelet count detects platelet levels of the patient. Prothrombin time screens for deficiency of factors 7, 10, 5, 2, and 1. INR assessing the clotting function of the blood, standardization of PT. A PTT method to screen for deficiency in the intrinsic pathway factors, including prekallikrein, HMWK, and factors 12, 11, 9, 10, and 8. The platelet count, as previously mentioned, is deficient with only 60,000 per microliter. The prothrombin time, which is a reference value of 10.5 to 14 seconds, is prolonged with 25.6 seconds as a result. The APTT also shows significant prolongation. Its reference value is 22 to 34 seconds. However, the result is 191 seconds. There is a characteristic APTT prolongation than PT prolongation. In summary of the initial test, platelets are deficient, both PT and APTT are prolonged.
In order to accurately determine the specific coagulation factors that are deficient and establish a definitive diagnosis, further tests need to be conducted. Additional tests that was ordered are the following. First is fibrinogen, which is used to evaluate the degree of clotting factor consumption, since on the initial testing, the PT is prolonged. Factor assays are conducted to precisely determine the factors that exhibit deficiency. Fibrin degradation products and D-dimer tests are done to assess the level of fibrinolysis. And lastly, antithrombin 3 is done to evaluate the severity of the anticoagulant deficiency and potential risk of thrombosis. Upon conducting the additional tests, here are the results. As you can see in the table, fibrinogen along with factors 2, 5, 9, 10, and 11 are deficient, while factor 7 is normal and factor 8 is slightly increased. In addition, factor 12 is normal while fibrin degradation products and D-dimer is increased. Lastly, antithrombin 3 is decreased. As you can see in the table, the summary of the results are indicated. The factors that are deficient are factors 2, 5, 9, 10, and 11, while factors 7, 8, and 12 are normal or slightly increased. Other abnormalities that are detected by the additional tests are increased fibrin degradation products, as well as D-dimer and decreased levels of antithrombin 3. Using this information, we can rule out other disorders that may be causing the severe thrombocytopenia of the patient. In cases of hemophilia, only the APTT is prolonged and subsequent testing must show a deficiency in both factors 8 and 9. Therefore, it is not the patient's condition since the factor 8 of the patient is slightly increased. In von Willebrand's disease, factor 8 is severely deficient. But in our case, as I previously mentioned, the patient has a normal level or slightly increased factor 8. Therefore, the patient's test results correlate to the characteristics of consumptive coagulopathy. In consumptive coagulopathy, it occurs upon the release of excess thromboplastin, which triggers the excessive generation of thrombin. Simultaneously, enzymatic conversion of fibrinogen to fibrin occurs. wherein plasmin generation simultaneously degrades fibrinogen or fibrin into FDPs. Therefore, excess FDPs are formed. FDPs, or your fibrin degradation products, have affinity for fibrin monomers but fail to polymerize properly, which causes excess FDPs, which have an anticoagulant effect. In summary, consumptive coagulopathy refers to the excessive production of thrombin, leading to widespread formation of fibrin within blood vessels and subsequent consumption of platelets and coagulation factors. Based on the tests conducted and upon ruling out other disorders, we can therefore say that the patient suffers from Kasabach-Merritt syndrome. Kasabach-Merritt syndrome is characterized by the following. First is hemangioma. Second is localized intravascular coagulopathy, or within a specific area or organ of the body. Severe thrombocytopenia, prolonged PT and APTT, elevated fibrin degradation products and D-dimer, decreased levels of antithrombin and fibrinogen, and decreased levels observed for factors 2, 5, 9, 10, and 11.
In the field of diagnosing coagulation disorders, medical technologists heavily depend on a wide array of laboratory tests. These tests play an essential role in both screening and identifying different types of coagulation disorders. Alongside this test result, it is important to consider the patient's clinical history as well for an accurate diagnosis. Performing this test requires great precision and strict adherence to establish protocols in order to guarantee dependable and correct results. Further expanding on this topic, there are several specific laboratory tests that can be used when evaluating possible coagulation disorders. I understand the importance of expanding my knowledge regarding new advancement in diagnostic methodologies as they become available so that I can continually deliver top quality care.